So this is a quick one. So this is 69-year female with history of abdominal pain, and the patient came to the ED. So I think we can start with the axial. So here we can see distended stomach filled with the fluid and multiple small bowel loops filled with the fluid and wall thickening as well, some ascites, and here we see some metallic density.
Is it a pill cam?
Yes, Dad. Yeah, initially we were confused what is this, yeah, but later when we looked at the radiograph as well, and also when we changed the window so much, we saw that it was a pill cam. So yeah, just nothing, not a difficult case, but a very nice case of a pill cam which got stuck at the stricture. Here you can see the terminal ileum and goes all the way stricture, and here is the ileocecal valve area. So a long stricture in the terminal ileum resulting into obstruction, and this pill cam got stuck in this area. Later, the patient underwent surgery and got ileocecectomy. So they removed, and this patient had Crohn's disease. And also we have other areas where we can see stricture, wall thickening, all sequelae of Crohn's disease. Yeah, that's the first one.
I have a question for you.
Sure.
So people talk about inflammatory versus fibrostenotic strictures. And they say that like the longer the stricture, the more likely it is to be an inflammatory stricture. The more that it has like this laminated appearance to the wall, the more likely inflammatory. And the thicker the wall, the more likely inflammatory, whereas fibrostenotic is usually shorter and the wall is thinner. So your stricture here to me seems like an inflammatory stricture rather than a fibrostenotic one.
So what is the significance of differentiating those two?
My understanding is that if it's inflammatory, it can be treated by anti-inflammatories like TNF inhibitors, whereas if it's fibrostenotic, it needs surgery because it's not, the inflammation cannot be decreased. In this case, maybe they still needed surgery because it was causing a relative obstruction, or I don't know, but I don't know. I'm curious what other people have learned or think about that.
So that would be only evident on MR only, or can we also say the difference on CT scan as well?
My thought here is that I still see features of inflammatory stricture on CT in that it's very long segment and it looks inflamed, like there's stranding around the wall, right? Like see how inflamed it is along distally?
Yeah.
And I can still see like some mucosal edema. So I don't think it's just an MR diagnosis. Okay,
gotcha. Thank you, Dad. The other thing is when I was reading something, it said the stricture, like significant stricture itself is not a contraindication for the pill cam, but like logically speaking, if the pill cam doesn't pass through, doesn't it cause issue? Because like they can't get it from the top and they can't get it from bottom. So shouldn't that be considered a contraindication, or shouldn't they do at least CT intergraphy or MR intergraphy before performing a pill cam study?
Usually they perform a sham pill cam study, like it's called what is it called? A patency capsule. They'll send one through that's not metal, it's not a camera, but it's dense. And they'll see if it gets through. And if that gets stuck, then they won't send the pill cam through if they're suspicious that the patient has fibrotic stenotic disease.
Gotcha.
Yeah. So you can see that on x-ray. You'll we'll often say like, oh, we think the pill cam is now in the rectum and, therefore it passed, or it's stuck at the ileocecal valve. Therefore, definitely don't give the actual pill cam.
Yeah, that makes sense. Thank you. So this is another case. So I think this is 43-year patient, and here on the right adrenal we can see a lesion. This looks predominantly T2 dark, but also one part of it is T2 bright, And so here we have in phase and out of phase images. Here we can see the T2 bright area, the T1 dark, and so most likely this is cystic area, and also it does not show enhancement, but the other side, the medial component, it's dropping on, dropping signal on the opposed phase images, and also it's showing enhancement. So it looks like part of it has intracellular fat and part of it is cystic. So the question is, what do we do next, or what should be in our differential diagnosis and what we could exclude?
What do you guys think? You can also type it in.
Aarti, we wondered if it can be some sort of a collision tumor.
Cool. Yeah. So collision between a lipid-rich adenoma and then what do you think the cystic part is?
Some kind of FEO, but it's not enhancing very much though.
I've seen hemangiomas and adenomas as collision as well.
So Aarti, I have a question. Like the general rule of thumb, we say if we see adrenal masses more than 4 centimeters with no primary history of malignancy, you have to consider surgical resection. Do you think they apply to collision tumors like this, which have like so much fat in one component, like it's an adenoma on one side, and then it's more cystic, like Anu said, is it like a hematoma or some pseudocyst or something that collided? Do you think that rule still holds good?
I definitely think so. And especially if you think it's a collision tumor, right? Like if it just looks like a huge adenoma and the whole thing is dropping out, then you're like, okay, there could be a rare malignant degeneration, or it could be like a clear cell.
But I'm saying the collided part is not looking very ominous here though, right? It's T2 bright, but it's not avid enhancing like.
But I don't like this enhancement, like this raggedy, like this top left picture. I don't.
That's still
like that. It's not like a lymphangioma or like something very just like a simple cyst.
Not
right?
simple. Yeah.
Yeah.
So then we get surgical consultation and it should come out, right?
Yeah, so I like the collision tumor idea. Like it could be part adenoma, it could be part FEO or MET. And adenomas are so common that, it could have just been an adenoma that like something else attached to. And it can also be cystic degeneration of an adenoma, but I think you have to pay more attention to it because of that other part.
Yeah, but when I found this, I found an article in AJR, which I think it's really good. I didn't know many things that I learned about it. I just made a few slides based on that. So here, most likely it is large adrenal adenoma, because it says when it is more than 4 centimeter, which it was in our case, then usually it results into cystic degeneration. And obviously when it is large and if the patient does not have history of primary cancer, then adrenocortical carcinoma should always be in the differential. And the other less likely is METS or collision tumor. So there were many studies which said, like if we did not have any history of primary malignancy, finding an incidental adrenal metastasis is super, super, super rare. So, and also they said the FEO is very, very unlikely. I think they only found 2 case reports till now where FEO had intracellular fat. So in our case, since we see part of the lesion is dropping on out of phase, so that means this lesion is very extremely unlikely to be even, like partly pheochromocytoma. That was the thing I learned. And as we already know about the washout, but washout versus chemical shift imaging, this was an interesting fact for me. It says that if the Hounsfield unit on non-contrast is more than 20, then the chemical shift imaging is not as good as washout study. And if it is more than 30, then it's even worse. So in non-contrast, if we see the Hounsfield unit between 10 and 20, then maybe we could go for chemical shift imaging to characterize. But if it's definitely more than 30 HU, it's always better to do contrast washout study rather than go for the chemical shift imaging using MRI. And we already know about this 15 minutes is better than 10 minutes, value 60-40.
Wait, I have one thing to say about the washout though. So you're basically saying if it's dense, you shouldn't, you should use washout instead of chemical shift imaging. But also there are caveats about washout, which is that PHOs and METs, for example, RCC METs can definitely wash out.
Yeah, sure.
Okay.
Yeah, so as you said, like METs from the clear cell RCC and SCC, they are very difficult to differentiate because they are hypervascular, so they can wash out within the adenoma range. And also, to make matter worse, they also have they might have intracellular lipid, so they can drop signal. So if the patient has history of these primary malignancies, and if we see those lesions, both of the methods that we described, chemical shift and wash out, are not good enough. And if you want to be quantitative regarding the drop in signals, so I found this formula and numbers 16.5% and ratio 0.7. And both of these are only applicable in 1.5T. I could not find the exact numbers for 3T, but the article said it's different, but I don't know how much exactly that is. The other interesting thing that I got to know was the myelolipoma. When we see, as a resident, when you see macroscopic pad, we say, oh, it's myelolipoma and we're done. But they said for that, the fat component should be at least 50%. If it is less than 10%, then it is more likely to be myelolipomatous metaplasia of either an adenoma or adrenocortical carcinoma. So that was a interesting fact that I got to learn. Yeah, and
But there's a big space there between 10 to 50%.
Yeah, so I think it's still we need
It's
some
very
research.
confusing.
Yeah. Yeah, those are the two cases that.
Cool, that's awesome. Wait, so what was it? Do you know?
No, actually, this is stable for last 6 months, so we are still following it up. But common things being common, my guess would be adrenal adenoma with cystic degeneration, and also given stability for the last 6 months. So we'll see that.
Yeah, I also favor that. But if you get follow-up, let us know.
Yeah, sure. Thank you.
Yeah, great presentation. Thank you. Christine?
Hi, let me share my screen here. So this case, because we don't see a lot of like pediatrics, at least where I am. So I wanted, so basically this is a 26-year-old, I want to say, man who came in with basically diffuse metastasis everywhere. So it looks, as we scroll down, you can see that there's a bunch of liver lesions, and it seems like the adrenal glands are involved bilaterally. And so is the bone marrow, very heterogeneous marrow signal. So he does have this renal lesion, which is actually T1 bright and T2 dark, so possibly reflecting some hemorrhagic products. And then on the subtraction images, like I would say the majority of the lesion is non-enhancing, and maybe very subtly, there's maybe like very low level enhancement along the periphery. So this ended up being a medullary renal cell carcinoma. So, so this actually, I did not show you the history, but this patient did have a history of sickle cell trait, and medullary renal cell carcinoma is strongly associated with that. So these are usually centrally located, infiltrative, with preservation of the reniform shape of the actual kidney. And just like this case, there's a predilection for the right side. There's typically extensive necrosis and hemorrhage like we see in this case. The hemorrhage actually could be intratumoral or subcapsular. And unfortunately for these patients, the mean survival time is only like 4 to 12 months. So I just want to show that because I haven't seen a case like this in a while. But I thought the enhancement was interesting in that it seems like the majority of the actual mass is necrotic, but there is some like subtle low level enhancement in the lesion.
Wow, that's like such a good example of like how aggressive it is, right? And even if you don't see much enhancement, that's like because it's so aggressive and necrotic.
Mm-hmm. Yeah, I just thought that was like, it could be tricky, you know, if you were looking at it quickly.
Yeah, and I guess we should be even more suspicious. Young person with a renal mass, if you see like a little bit of that enhancement, you know, like you should be more
Mhm.
suspicious. It could be something aggressive.
All
Cool.
right.
Anyone else have stuff? Okay, so this is my first case. It is a 30-year-old female with pain with intercourse and primary amenorrhea. So what do you guys think? Oops.
There's no uterus there.
Okay, good. So there's no uterus. Do you think there's a vagina?
Yeah,
like, when do
exactly. I
we-
was going to say the vagina looks, I mean, there's just a thin septum of some sort there. It doesn't look like there is one.
Yeah, so I'll go to the axial here. So normally you've got your urethra, your rectum, and then we should have like an H-shaped vagina. Instead, we just have this very thin, dark thing that like immediately goes away. So the vagina is really also not developed. There's no uterus. That explains why she has primary amenorrhea. And we did not see any ovaries. So what would you call this? Actually, there is this one thing here. Not sure what that is, but not sure if it was an ovary. So what would you bring up?
Agenesis, like Mullerian agenesis.
Are
Okay.
external features female?
That, yeah.
Yeah, so far, I mean, generally there was no testes or anything like that.
No surgery, no hormonal treatment.
Nope. Yeah. So the primary thought is this Mullerian agenesis or Meyer-Rokitansky-Kuster-Hauser syndrome. But there's two other things that we need to bring up. So there's the typical type, which is type 1, where you have agenesis of both the uterus and part of the vagina, could be different extents of the vagina. But normally the ovaries are normal. There's atypical, which is type 2, where you have both agenesis of the uterus and the vagina, but you also have other abnormalities, possibly of the ovaries and the kidneys. And then there's another thing that you have to think about with when you don't see a uterus. Does anyone have any thoughts?
Kidneys?
Huh?
Kidneys?
Yep. So that's in the type 2 atypical type where you could have kidney abnormalities, but and one other diagnosis.
Maybe.
This is kind of like you guys were asking about the external genitalia and if they seem female, but it can be tricky. So anyway, the other thing is it could be androgen insensitivity syndrome, where it's actually a male, but they're having androgen insensitivity. And therefore, that's why they don't have a uterus, but they might have like undescended testes. They might have undeveloped penis. So like, you know, you're like, is this a large clitoris or a micro penis kind of thing? So that's another thing to think about. And so two of the things they need to do here when you see this is they need to do karyotyping to see if this is XX. So this is truly a female, or it could be XY and they have androgen insensitivity, in which case you can also test their testosterone levels. And then the other thing is to decide if you think that the ovaries are normal. So it's like a type 1 versus a type 2. In type 2, they'll have spinal abnormalities also and renal. So it's much more severe. And you need to do imaging also of their upper tracts. I don't have the answer yet here. We just saw like basically there was no uterus. There was like half the vagina was not there. And there was this one structure that could have been an ovary, but you know, it's still possible this could be an undescended testicle. So you need to think that maybe this could be a male. They should get karyotyping. They should test their testosterone. Any questions? Okay. This is my next case. This is an 80-year-old female presented with this liver lesion and some right upper quadrant pain. She didn't have any history of liver disease. She has this large lesion. This is the arterial face. So we can see that there's like nodular arterial enhancement. Venous phase, we're getting some more enhancement. This was the delayed. And I'll show you the T2. So Christina's saying cholangio.
I'm thinking of a solitary fibrous tumor, large.
Okay, why?
Along those lines, because the T2 dark component enhances progressively. There's like a thick rind of enhancement. This is definitely not a cavernous hemangioma. Cholangio is a good thought. And the other thing I feel is, does this have a lot of fibrous tissue in it or mesenchymal tissue?
Good. So my main teaching point here is this is not a hemangioma. And this actually was initially called a hemangioma. And so I want to, because of this arterial appearance, and you can see how it can be tricky, right? It looks globular. It kind of looks like a hemangioma. Maybe it's progressively filling in. You could think it could be a cavernous hemangioma, but the trick, the key here is the T2, where this really does not look like a hemangioma, which should just be like pretty bright and may even have like a brighter central scar here. So all of this looks dark, fibrotic, heterogeneous. So this is not a hemangioma. This was biopsied, and this was actually a large HCC.
That is interesting too. This is
yeah. And I've actually seen a couple of
HCC.
I've had several HCCs that look like this, and actually like literally several where people accidentally called it a hemangioma.
Was it subtyped? There are different subtypes of HCC. So
they said moderately differentiated.
Oh, okay.
And then they did test it for like a bunch of, they tested it for like different mutations and stuff, but I didn't take note of that. What are the different subtypes? I only know like poorly differentiated, well differentiated.
Yeah, no, you can have like the clear cell subtype of HCC, sarcomatoid. Like there are a couple of subtypes of HCCs. So yeah.
This one had actually also grown over time. So the initial one was actually called a hemangioma. Then when it was growing, they were like, wait a second, this is 80-year-old patient, shouldn't have a growing hemangioma. But it's kind of crazy how, it's mimicking a hemangioma here.
Agreed.
Okay, this is my next case. This one's a little bit of an eye test. So tell me if you guys see anything. I'll just scroll through the area where the abnormalities are in this area. Okay, I'll point it out unless anyone wants to speak up. So the first thing my colleagues noticed were these lymph nodes. So, is it normal to have mesenteric lymph nodes? Younger patients can definitely have larger nodes, especially in the right lower quadrant. They can get a mimic of appendicitis, which is called mesenteric adenitis, if they have more than 5 large lymph nodes that are just kind of inflamed. But, when you see these lymph nodes, this should be like, what's draining to this? Is this a neuroendocrine tumor met, colon cancer met, etc.? And as we look closer at the colon, you can actually see here, there is a solid part of the colon. Super, super easy to miss, especially if you're not running the colon, and especially if those lymph nodes were not enlarged. But we can see, actually, this turned out to be an adenocarcinoma. This was one of the metastatic nodes, and these were the other 2. So we've said this at this conference multiple times, but you should run the entire colon. And also you should always look at the mesentery. And if there's any enlarged lymph nodes, look at the nearby colon as well as small bowel, make sure there's no primary tumor. Another interesting thing about this biopsy. This turned out to be adenocarcinoma, but it was microsatellite stable. And Nellie has talked about this before in this conference. Does anyone remember what that means?
Aarti, we vaguely remember that the treatment changes with MSI versus not MSI.
Yeah. Okay. So I had to relook it up because I did not remember. So I'm not calling you out. I'm saying like, I didn't remember this, but every time I have to look it up. So anyway, this one, so if it's MSI, which is microsatellite instability, that means that it's possibly Lynch syndrome, and it's also associated with multiple other malignancies. These are associated with also colon cancer, but also gastric cancer, endometrial, ovarian, hepatobiliary, urinary tract, brain, and skin cancers. So it's like a harbinger that you might also have other cancers, and if not Lynch syndrome. But microsatellite instability is also, they tend to do better. They have better prognoses. They actually tend to be in the right colon versus the left, and they have less metastatic disease. So it could mean that you might develop other cancers, or you might have Lynch syndrome, but the colon cancer itself has a better prognosis with less metastasis. This patient had a, just kind of bread and butter colon cancer. It was microsatellite stable, not unstable, was not part of Lynch syndrome. And then it does change their treatment.
Aarti, can you show coronals?
You're wondering if you would have seen this?
Always, right? Steve showed a case like this too, right? Where the coronal, okay. Hopefully.
There's the cancer and there's the nodes, but the nodes are really helpful here, right? Because that would be easy to miss.
They're like
lead on colonoscopy, it was a 3 centimeter cancer.
The nodes somehow look bigger.
Yeah.
I'm sure they're smaller. I'm just kidding, but
No. But I mean, that was actually the point of like when my colleague brought it up, is like, you usually think like, if you're going to have these nodes, the mass will be bigger, right? But not always.
Yeah.
It's pretty aggressive. Okay. This is a pretty interesting case. So this was a year ago. Focus on the pancreas. You can see that the duct is very dilated. This is the head of the pancreas. Maybe this is like the common bile duct and the pancreatic duct. Or wait, let me see. Oh, actually, this is probably the main pancreatic duct, and maybe this is like an accessory duct. What do you guys think?
main duct IPMN is something that comes to my mind.
Yes, excellent. Somebody else check. Oh, and Christine says main duct IPMN. Yeah, and I think Melina, my colleague who's on this, presented this. So exactly, this looks like a main duct IPMN, super engorged duct, lots of mucin in it. That's what I would think about. It's interesting, in retrospect, there was also some ascites, but maybe there's some other reason for that. So anyway, they go in, they do a Whipple, because when you have a main duct IPMN, your goal is to not do a full pancreatectomy. You want to preserve some of the pancreas so they don't become a brittle diabetic. So they said, okay, this is the bad part. They did a Whipple, and then they got frozen margins, like they got frozens on the margin, and they basically march along until they see low-grade dysplasia, and then they stop cutting. So the margin was low-grade dysplasia. And then actually the rest of this, they said, was a 5 centimeter IPMN with low and high grade dysplasia, but no definite invasive adenocarcinoma. There was some parts where it seemed fragmented, but they got a second opinion and they said there was no invasion. And then a year later, this is what their abdomen looked like. So the remnant pancreas is here, but all of this is poorly differentiated mucinous adenocarcinoma throughout the abdomen, all of this caking, extensive, exuberant mucinous cancer. So we thought this was an interesting case, that, the primary tumor was resected. It didn't even have an invasive component. but somehow maybe they missed, or we missed, some of it had already gotten out, and maybe that's why they had ascites on the initial one, and they already have this like poorly differentiated mucinous metastatic disease. So this is kind of also like, especially main duct IPMN, those have a worse prognosis, much more likely to have invasion, more likely to metastasize. And in this case, we definitely have that happening. It was actually the most shocking case I've seen. Even main duct IPMNs that I've seen, I haven't seen it like metastasize like this. So I'll just show you the post contrast too. Any comments?
Just sad.
Yeah, see, and you can see it's not enhancing very much, but there is this, kind of wispy, cloudy enhancement in it. That's from like the adenocarcinoma within like a mucinous kind of background. So this is a good look for mucinous adenocarcinoma.
I thought they just get rid of the entire main duct IPMN.
No, usually they try not to, because if you get rid of the whole pancreas, then not only are you not making insulin, but you're also not making glucagon. And so not only will you become an insulin dependent diabetic, but it's a brittle diabetic in that the glucagon is not allowing your liver to release glucose. So it's actually very dangerous, right? Because they'll have these catastrophic hypoglycemic episodes. So for just quality of life issues, they really try to preserve at least part of your pancreas. And you only need about 10% of your pancreatic islet cells to have enough insulin. So they'll do and usually the malignant degeneration is in the head. So they'll often do a Whipple and then get the frozen sections and kind of like stop whenever there's just low grade dysplasia. And then they'll surveil the gland, the rest of the patient's life. Okay, last case. Patient with sort of vague symptoms, mild right upper quadrant pain. What do you guys think?
Any travel history?
Nope. They are Asian. I'll just put that out there, but what are you thinking? Swachchhanda says hydatid. Okay, good thought. I'll talk about that in a sec. Anything else?
Abscess, like amoebic abscess.
Yeah, so amoebic or bacterial. So anyway, the other thought when this came up was like, is this a mass? Is it a cystic and solid mass? I would say a couple of things go against that. Like here you can see there's like a bubbly border. So it doesn't have a capsule, whereas mucinous cystic neoplasms, formerly biliary cystadenoma, like will have a capsule with ovarian stroma in it. So this doesn't look like that. So I think, and then it has this little bit of hyperemia around it. So that also looks inflammatory. Oh yeah, even up here, narrow it, there's some perfusion abnormality, either from like a portal vein being out or just from the inflammation. So I agree. I think this is more of like an infectious process. Also, a hydatid cyst usually has a capsule because the exocyst is basically your body laying down like fibrotic layer around the outside, around the infection. So it doesn't usually have this bubbly border. This bubbly border is really good for an abscess. Usually they are micro abscesses that shower a part of the liver and then they coalesce into a larger abscess. But because they started off as micro abscesses, you can see small little abscesses along the periphery. So anyway, the other thing about this patient, they were an outpatient and they weren't really having that many symptoms. So the other question that often comes up is like, could this be an abscess if like the patient's not very symptomatic? And what I've seen is that like abscesses can be very asymptomatic, especially if they're kind of going on for a long time. Maybe the patient has vague pain, maybe low grade fevers, etc. They ended up getting an MRI I think a few weeks after that initial CT. You can see that there's like this thick rind of inflammation. There's liquefying parts to this abscess. There was also restricted diffusion in the liquefied parts. So that's actually a good clue for an abscess versus a mass. So you can see that it's not like the thick rind along the outside is where the restricted diffusion is. It's really in the liquefied part. And if we go to the ADC, we can see that there's a lot of restricted diffusion in the liquefied part. So that's very good for liquefied dense cellular area in an abscess, rather than necrotic mass, where the central part might not restrict, but the periphery where there's like viable tumor might restrict. So anyway, they put a drain in, and I'll just show you the latest. So the latest CT, and you can see that the drain, they put it in that big, large bore drain should go transhepatic into like the big liquefied part. The abscess looks much, much better.
Do we know what organism they got?
Yeah, I was waiting for you to ask. Actually,
Yeah.
very disappointingly, both the blood cultures and the abscess cultures have not grown anything, which kind of, for me, doesn't prove that this is an abscess, but I'm convinced it's an abscess, and it looks like it's getting better. But maybe it was so far along, it's been going on for months, that like basically everything that they were able to suck out of this is all just like necrotic debris. There's no actual live, bugs in this right now.
Interesting.
Another good point is to, whenever you have an hepatic abscess, always look at the GI tract to make sure you look for the primary, like was there colitis, was there appendicitis? 50% of the time we will never find what the initial inciting event was. And then the other thing is always look at the SMV and the portal vein, because the bacteria often goes through there, you can get thrombosis of those vessels, like a septic pylephlebitis. And actually, I don't see the anterior division of the right portal vein here, so I think it's at least thrombosed right there. Okay, that's it for me. Anyone else? Okay, we will go. Have a good rest of your week, and I'll see you guys at SAR. Although I think it's like a month away, but I'll see you guys soon. Bye.
Thank
Bye.
you.
Melina, I'll see you next week. I'll be back at work.
Bye.
Bye.